First of all, I would like to welcome all of you and for this evening that we are going to discuss two very important topics. I have the pleasure of we are here on behalf of Bayer Company, and we have the pleasure of me and Dr. Bassem Zarif, who is joining us to talk today about rethinking prevention, primary versus secondary strategies in cardiovascular disease. I am Dr. Adel Tash. I am a consultant cardiac surgeon. In fact, I don't talk about this subject a lot, but because of my passion and because of my position as the lead for cardiac services at the Ministry of Health and the general director of the National Heart Center, I got interested in cardiovascular risk calculations, and we in fact developed, as I'm going to discuss later on, a national cardiovascular risk calculator. I also work as the chief executive officer of King Abdullah Medical City in Mecca, and one of the biggest departments we have and the biggest services, which comprises around 40 to 50% of our services, is our cardiac services. So today I'm going to start off. Welcome, Dr. Bassem. But
Most
Dr. Bassem,
welcome.
yes,
The
thank you.
honor is mine.
Oh, the honor is all ours. And of course, I would like to thank the Saudi Heart Association for organizing this session. And I would like to thank our sponsor today, who is a Bayer company. Uh, so cardiovascular risk calculation, let me just organize my stuff here. Okay, so can you see my slides? I can't seem to move it. Yes, okay. So, what is cardiovascular risk calculation and why risk estimation matters? As you all know, cardiovascular or atherosclerotic cardiovascular disease remains the leading cause of death in the Kingdom of Saudi Arabia, comprising of around 40% of mortalities. You also know that the largest gain from any initiative we do for heart disease or heart attacks in general, acute coronary syndromes, STEMIs, non-STEMIs, is going to be in the field of prevention. We have been doing this for a long time, and we notice that the more we do acute, we just manage acute cases, the more they come in. So we have to really go down the stream and look at how are we going to prevent. And risk calculation is the best way in really organizing and structuring prevention, where we determine the lipid, the blood pressure, and antiplatelet decision early, especially in the primary healthcare clinic settings. Local calibration with the calculator, as we're going to discuss later on, will avoid over or underestimation, which is seen with important tools. And the takeaway here is accurate risk assessment leads to timely therapy, leads to fewer events. So, what are the learning objectives from my talk? I think it's going to be brief and quick, but we will compare major risk calculators and their population. We will choose an appropriate tool by setting and patient profile, and we will translate risk categories into therapy thresholds, and we will apply the KSA National ASCVD calculator in primary healthcare clinics and specialty clinics. Key concepts. We always look at absolute versus relative risk, 10-year versus lifetime risk. We discriminate the discrimination versus calibration trade-off. The trade-off matters, and population calibration and transportability. So data inputs that drive calculators. The first is, of course, the personal, the age, the gender, and the ethnicity. The clinical, the systolic blood pressure, total and high density lipoprotein cholesterol, smoking, diabetes, and chronic kidney disease. Treatment status, hypertension treatment. Is the patient on statin or not? Is the patient on aspirin or not? And some optional which factors which we will be talking about. So the global landscape for risk calculators. The first is the patient cohort equations, like the what is used with the American College of Cardiology, American Heart Association. We adopted a similar calculator in Saudi Arabia. It calculates risk for patients age 40 to 79. It may miscalibrate outside the US as race determines that. In Europe, they use the score 2 or score 2 op, and the outcome of that calculator is fatal and non-fatal cardiovascular disease. It also calibrates between or checks risk for ages 40 to 69, and then it has a different calculation for 70 to 89, which makes it a little bit more accurate than the patient cohort, and it's calibrated by region. The QRISK-3, the UK primary care data, it uses UK primary care data, and the final outcome is cardiovascular disease. It has a much wider range from 25 to 84, and many comorbidities and medications affect this score. The WHO 2019, 21 global regions. The outcome is MI and stroke, any age above 40. Lab and non-lab versions are available. The MISA coronary artery calcium score, US multi-ethnic. The outcome is congestive heart disease and ASCVD from 45 to 84, and risk refiner using the CAC or the coronary artery calcification. So the PCE, ACC, AHA, the patient cohort equation, target patient population, the risk estimator is intended for use in patients at risk for atherosclerotic coronary artery disease and atherosclerotic coronary artery disease related events, especially due to dyslipidemia and hypertension. The variables here that we have in this calculator are age, sex, race, systolic blood pressure, total cholesterol, HDL, smoking, diabetes, and blood pressure medications. The output is a 10-year ASCVD risk. Categories less than 5, 5 to 7.4, 7.5 to 19.9, and more than 20%. The pitfalls, it over or underestimates in non-US baseline statin use. The score 2 was done from using European patients age 40 to 69 years without prior cardiovascular disease or diabetes. The score 2 op used in primary care settings to estimate the patient's 10-year risk of fatal and non-fatal cardiovascular disease in European patients more than 70 years without known cardiovascular disease. The pitfalls it's not validated outside of Europe. Clinicians in other regions should interpret results with caution, and it does not account for additional risk enhancers like family history, chronic kidney disease, inflammatory diseases, and should not be used in patients with established cardiovascular disease as the risk is already high. The QRISK-3 variables, the variables for the QRISK-3 risk prediction algorithm includes demographic factors like age, sex, ethnic origin, deprivation, and family history of coronary heart disease. Lifestyle factors like systolic blood pressure, body mass index, smoking status, and alcohol intake. Medical conditions like type 1 and 2 or 2 diabetes, treated hypertension, chronic kidney disease, rheumatoid arthritis, atrial fibrillation, and newly incorporated variables like corticosteroid use and systemic lupus erythematosus, SLE. The pros and pitfalls, the primary pitfall of QRISK-3 include underestimation of risk in specific patient groups, such as those with COPD and older individuals, leading to potential missed interventions. And other weaknesses are limited generalizability to heterogeneous populations like the UK Biobank cohort, a lack of transparency in how life table patterns of cardiovascular disease risk are calculated by, by the developer. The WHO cardiovascular disease risk charts designed for resource appropriate settings, lab and non-lab models. So we have two models. We could have a model with that we don't have an access to a lab, and we can do more patients, and a lab model. It's region-specific charts across 21 regions. It's useful for primary healthcare programs and screening. Uh, Special features: diabetes, familial hypercholesterolemia, chronic kidney disease, pregnancy, postpartum inflammatory disorders. It considers disease-specific tools and risk-enhancing factors. When in doubt, escalate assessment, like go for a coronary artery calcification. The MESA risk score and coronary age calculator, an accurate estimate of a 10-year coronary heart disease risk can be obtained using traditional risk factors and coronary artery calcium. The MESA coronary heart disease risk score, which enables calculation of risk both before and after inclusion of an individual's coronary artery calcification score, can be used to aid clinicians in the communication of risk to patients and when determining risk-based treatment strategies. The coronary age calculator provides a convenient transformation of the MESA 10-year CHD risk score into a scale that may be more easily appreciated by both patients and treating physicians. From risk to treatment, conceptual thresholds. So the risk tier, as we said, we have 4 tiers in risk: less than 5, 5 to 7.4, 7.5 to 19.9, and more than 20. So the lipid therapy we have here is for less than 5, a lifestyle risk, and consider coronary artery calcification if risk enhancers. And aspirin is not recommended, and the target blood pressure is less than 130/80. Now, from 5 to 7.4, consider a statin, a moderate statin, if enhancers and the coronary artery calcification is more than 0. We want the blood pressure less than 130/80, and aspirin therapy, generally, from 7.5 to 19.9, which is a moderate risk, moderate to high statin, or moderate to high risk, moderate to high statin, coronary artery calcium to refine that. So if it's less than or 0, then we could stop the statin. If more, then we could escalate the statin. Blood pressure, we want it less than 130/80. And in select cases, we do give aspirin, but we make sure about the bleeding risk. More than 20%, high intensity statin plus minus non-statins, ezetimibe, PCSK9 inhibitors, and so on. The target blood pressure also less than 130/80, and aspirin avoid unless compelling. So implementing risk in a busy clinic. This is probably the bottleneck of all what we're saying, is that whenever we talk to primary healthcare clinicians, seeing those patients that are not diagnosed with ASCVD and asking them to do the calculation is the process of calculating the risk, capturing the data, choosing which tool, doing the actual calculation, assessing the risk tier, and putting the therapy prompts, and documenting and recalling all that for the next visit. So that's the real challenge. If we can educate and make sure that they have the time, the resources, and the knowledge, the primary healthcare clinics, to do this job, then we will definitely win this battle against ASCVD at its prevention level. We and at the National Heart Center developed a national ASCVD risk assessment calculator in KSA. The ASCVD risk assessment tool is a preventive measure designed to estimate the 10-year risk of developing ASCVD among adults in KSA based on factors such as smoking status, blood pressure, total cholesterol, diabetes, and various health metrics. The ultimate goal is to reduce the incidence of ASCVD, a leading cause of death in the country. The purpose is to accurately classify across PHC and cardiology, unify clinical pathways and medication access, promote standardized evidence-based care. The impact: it will promote digital transformation in cardiac care, decrease burden of ASCVD disease on the health system, empower healthcare practitioners to calculate ASCVD risk for the individuals in KSA. And the benefits: it's standardized pathways aligned with policy. And we do have a web app plus a QR for point of care access. And the QR is on the screen now. If you want to capture that QR, this QR code will take you directly to the site or the calculator on our National Heart Center site. So yeah, just why is this? Okay, just one second. I think I just missed a slide. Okay, I just want everybody to take a moment to take a brief look at the QR code. Okay, so the National ASCVD Risk Assessment Calculator in KSA calculator inputs and outputs. Inputs: age, sex, systolic blood pressure, total cholesterol, high-density lipoprotein and low-density lipoprotein, smoking, diabetes, coronary artery calcium score. The coronary artery calcium score is optional. Modifiers: chronic kidney disease, treatment status, hypertension treatment, statin, aspirin, family history, premature coronary artery disease, hypercholesterolemia, metabolic syndrome, and chronic inflammatory conditions. Output is a 10-year ASCVD risk color-coded strata. So it will give you like a message, a 10-year estimated risk for hard ASCVDs, 1.6, which is low risk, or whatever. This is just an example. So this is the point of care flow in Saudi. We mentioned all that: capture data, choose the tool. The tool is already there. We can calculate it. It takes moments. It is a lab-based, so we do need blood results. It's a risk. It gives you a risk tier. It gives you therapy prompts, and it documents and recalls all that. So KPIs in monitoring coverage: percentage of eligible adults 40 to 79 years of age with documented ASCVD risk score in the electronic health records. Treatment appropriate percentage of patients in each risk tier started on guideline concordant therapy, statins, blood pressure targets, aspirin, avoidance in low risk, and follow-up adherence percentage of high-risk patients with repeat risk assessment for clinic follow-up within 6 to 12 months. These are the KPIs that we are monitoring for this risk assessment calculator. This is what we found from the cases we done. We done thousands of cases. I don't have track of how many patients we have on the calculator, but 46% were low risk. Intermediate risk was 20, borderline was 13%. But look at the high risk, 20%, almost 20%, and the intermediate risk, which deserve attention. The intermediate risk patients are probably the tipping point where between the low and the high. But you could see that I think around 42% or 41% of patients need active attention based on the risk calculator score. In conclusion, The cardiovascular risk calculators are essential tools for prevention and early intervention. Global tools are available. We do have a national ASCVD risk calculator in KSA, and embedding the calculator in the workflow can significantly improve equity, treatment alignment, and outcomes. The recommendations adopt the national ASCVD risk calculator in all PHC and cardiology clinics. We did that now in Mecca, and now we're getting more and more patients with controlled blood pressure, controlled lipid profiles, and controlled diabetes because of this calculator. Train clinicians and staff on workflow integration and patient communications, monitor KPIs, coverage, appropriateness, equity, and outcomes at cluster and national level, and iteratively update the calculator and pathways with new evidence and Saudi data, and promote patient engagement by sharing results virtually and linking to lifestyle counseling. And thank you for your attention, and looking forward to listening to your questions. I hope that I delivered a clear message, and looking forward to your thoughts, questions, and interactions. Thank you very much.
Thank you so much, Professor Adil. You will answer questions, or I can proceed?
I think, Dr. Bassem, why don't you proceed, or we can take a few questions.
Okay.
And then, but let me see how I can unshare here. I don't know how to unshare. Okay. Am I still sharing, or Rahman?
Yeah, huh? I have a comment for you that I want to congratulate you on having your own risk scores that representing your nations, and let me congratulate you for this work. I think it's a very important milestones in defeating atherosclerotic cardiovascular disease and succeeding in controlling of this burden. And I think one of the most killer all over the world. So congratulations.
Thank you very much, Dr. Bassem. Thank you. I think in the Q&A, am I still sharing? Well, you can share your slides.
You want me to start sharing?
Yes, go ahead. Okay, and in the Q&A section, I don't see any questions. So why don't you go ahead? I'm going to mute myself.
So it's a pleasure and honor. Thank you so much for the Saudi Heart Association for the kind invitation, and thanks for Bayer for inviting me to deliver this important talk. And I can't hidden my feelings that already honored to have the presentation of Professor Adil, and how much it's a proud to have regional risk scores for our patients and our brothers in Saudi Arabia. It's a special congratulations for them. Rethinking my talk about rethinking prevention for primary and secondary strategies, and we'll have a global view worldwide, and we can apply it to our current situation in the region, and of course in Saudi Arabia and here in Cairo. This is my disclosure. This talk was sponsored by Bayer. Rethinking primary prevention. I will talk my talk into two horizons. First, primary cardiovascular disease prevention, and the second is secondary cardiovascular disease prevention. Going to the basic data that already cardiovascular risk factors are any condition that or habit that increase the personal likelihood of developing heart or blood vessel disease. It should precede the cardiovascular disease. The more the risk, the more the risk factor, the more cardiovascular disease, and controlling risk factor decrease the incidence of cardiovascular disease. Of course, it's basic to know that modifiable and non-modifiable cardiovascular risk disease with lifestyle habits and social, going from non-modifiable age, gender, ethnicity, genetics, to modifiable, the main diseases of high blood pressure or elevated hypertension, cholesterol, HDL, and smoking and diabetes, going to lifestyle, smoking, diet. It's basic to know this data, but I want to share with you an important forecasting about traditional risk factors for the coming 25 years. This is just published data about risk factors globally and how every region in the world have its own risk factor map. Although high blood pressure or elevated blood pressure is preceding as a risk factor, but also high LDL, high body mass index and obesity, and high blood sugar are preceding. So preparing a map how we can control the risk factors in our region or our country, we have to make sure that we are having a specific map for every region and for every nation, and this will help a lot in planning prevention measures. As Professor Adil had just mentioned, there is global cardiovascular disease risk scores for primary prevention. As I already mentioned, European score 2 and its variant score 2 older patients and score 2 diabetes for European population. American pooled cohort equation PCE recommended by American College of Cardiology and American Heart Association, and the more recent PREVENT score, another Reynolds score and Q scores, as already had been mentioned, and specifically our Saudi Arabian score. How risk scores develops? Risk scores develop by analyzing data from large population, large cohort of patients, like the older Birmingham, recruiting a lot of patients, following them up for years and having data. Then researcher uses this data to create mathematical equation that incorporates variables like age, sex, blood pressure, cholesterol level, and the smoking habits to predict the 10 years risk of cardiovascular event. And finally, once the equation or the scores have been developed, it should be validated in a group of patients to ensure its accuracy. But I have very sad news for you all. And I have a question for the followers. Rethinking primary prevention. Do all myocardial infarctions patients classified as high cardiovascular risk before the event? Anyone can have the answer for that? And literally, or myocardial infarction patient, if you put them in a risk score, we'll find them all that having a high risk. Unfortunately, no. This may have different explanation. Maybe risk assessment tools are imperfect and in a continuous process of development. May have younger patient often lacking traditional risk factors and a lot of possibility. But you have to know, not all patients or individuals, when we put them in the risk score and for primary prevention, find them at high risk, those patients will get a myocardial infarction. Sometimes we got a myocardial infarction in apparently low risk population. So this is an important that we are getting out of the risk scoring to go a global vision about patients in the primary prevention, go to prevent equation, a new era of cardiovascular disease risk assessment as risk. As I told you, the forecasting for the 25 years coming for the traditional risk factors are different by regions all over the world, changing risk factors landscape with endemic of obesity. And I think our region having this problem increasingly till now, the increase of diabetes, longer life expectancy. So we have trends in cardiovascular disease with increased heart failure, decreased type 1 myocardial infarction, and increase in stroke prevalence, with preventive measure to go for higher statin and the new drugs that will control obesity and diabetes to prevent cardiovascular event, and think globally, merging cardiovascular risk factors for kidney risk factors, kidney insult risk factors, and the metabolic syndromes. Having this all together may have a comprehensive view to overcome the foreshortening of having scores in evaluation of patients in primary prevention. And this is an important issue, like the inertia to start treatment for patients in primary prevention, leaving them for years exposed for LDL. Once they got the threshold, multiplying the LDL by years, getting the threshold of 5,000, which is total black burden, this is the age that already the risk of MI is increasing. So when we are leaving our patients for years exposed to LDL, we may have their infarctions early in life. It is not the absolute number, but also the time exposure to LDL. This is an important thing to explain why not all patients with presenting with myocardial infarction have already high risk at risk scoring. So debates issues in primary prevention to look after new factors. We can call them as risk enhancers and their position in the armamentarium of risk scoring. The use of aspirin in primary prevention, and the data that already we have it that the risk of bleeding outweighs the risk of benefit. So who in the primary prevention, although it is a solid in secondary prevention to use aspirin in the primary prevention, we have to know who is the population in the primary prevention that needs aspirin in particular. Statins, and using statin early in life for low intermediate risk population. This is an important issue to know and have insights about it. Role of hormonal replacement therapy, role of lipoprotein letter A, equality of care and the availability of care for every district is an important issue and debatable issue in primary prevention. And finally, implementation and inertia in some issues. This is a very important, and I would like to highlight the issue I just told about leaving our patients with inertia to treat with mildly elevated LDL over years will resulted in exposing this patient for getting the first myocardial infarction early in life. So talking about, I will not go through the whole list, but I will highlight some factors about debatable issues in primary prevention. And this is the American guidelines for hypercholesterolemia 2019. So they are having on the side the atherosclerotic risk enhancers like family history, chronic kidney disease, metabolic syndrome, inflammation, autoimmune diseases, and they are particularly highlighted high sensitivity C-reactive protein, lipoprotein little a, ApoA, protein, and ankle brachial ratio, ankle brachial index to re-stratified patient. And risk enhancers are using as a tool to up classifying the risk of our patients, because once they have low, intermediate, and high risk, so adding calcium scoring take the decision will help us to take the decision early to statinize our patient, to early use of statin for our patient. So same integrating risk assessment using, this is data from US about South Asian population in the United States and how they use the risk score using the genetics and the origin of the patient to multiply the risk using the risk factor, traditional well-known risk factor, then risk stratify to low and borderline and high, and apply personalized risk, adding coronary artery calcium score to reclassify our patient and upscaling our patient to define who will get benefit of aggressive risk factor control to avoid getting the first myocardial infarction, as I told you. And this is the pathogenesis of atherosclerotic lesions and how the penetration of lipid and formation of a lipid core to have an pre-atheroma, atheroma, fibroatheroma, and complicated lesion, the process of lipid deposition inside the artery, and consequently, for wear and tear, calcium deposition in the arterial wall, starting from score 0 to less than 100 in fibroatheroma to the advanced level of complicated lesion, speaks of active penetration of lipids and indirect assessment of atherosclerotic coronary arteries. And this is how, as elegantly pointed out by Professor Adil, how coronary artery calcium for allocation of aspirin in primary use, how calcium score less than 100 or equal or more than 100 allocate patients for patients with high calcium score to get the more benefit starting early aspirin in primary prevention. So in absence of a high bleeding risk, aspirin is likely to be beneficial in individuals less than 70 years of age with a calcium score more or equal to 100, and they have an absolute net benefit with its use to outweigh the possibility of the incidence of GI bleeding, which accounts for 1 or 2% a year. So the benefit in apparently healthy or apparently primary prevention with a high calcium score, so they will get the much benefit improving their outcomes and preventing myocardial infarction without more expenses of GI bleeding. Same in multi-ethnicity study atherosclerotic participant, calcium score between more than 100 but less than 114. This is number needed to harm, and this is number needed to treat. Number needed to help or to treat 2 folds to 8 folds more likely to prevent heart attack with aspirin using than to have major bleeding secondary to aspirin. So using aspirin for primary prevention guided by calcium score had helped a lot of patients to improve their outcome without compromising these results compared to the risk of bleeding. Another issue, using carotid ultrasound-based black score for allocation of aspirin primary prevention cardiovascular disease, multi-ethnic study using not calcium score, but using carotid plaque score. Once we go for higher level of plaque score, the number needed to treat are essentially low. So they will get the more the benefit, and still the number needed to harm or having GI bleeding will be so high. So the net benefit in favor of using aspirin in this population with carotid plaques. Strategy to reduce aspirin bleeding, of course, coated aspirin, and of course using of PPI, and important to know to avoid bleeding risk and improving the outcome, having the benefits of using aspirin early to prevent high-risk population, whatever they are identified by calcium score or carotid plaques, without getting them into GI bleeding. To conclude, this is data, of course, secondary prevention. This is data for women. For secondary prevention, calcium is completely okay. For all patients with primary prevention, maybe no, but this is a specified population that will get the most benefit using calcium score or carotid plaque assessment. So the second part of my talk will direct it into secondary prevention, and I want to ask you an important question. Are all patients with secondary prevention at very high cardiovascular risk? Of course, yes. But are all in the same basket? So having an event before, so it's a very high risk, and that's it. All are the same in the same basket and having the same risk? Of course, we have to know, and this is an important slide from European Society of Cardiology. 2019 that in patients, especially those who have not revascularized by PCI or coronary artery bypass grafting, they have a peak of risk for the first year post-event. So this is the different risk lines according to the risk factors and whether the patient get revascularized or not. But especially if the patient is not revascularized and having multiple risk factor, there is a peaking of risk in the first year post ACS. And this is an important data just published recently about high risk population in secondary prevention. And this is data from cardiac rehabilitation just published few weeks ago about those who are at high risk, and they are classified them as 2 or more cardiovascular event within the previous 2 years, considered an extreme high risk. 2 or more vascular districts are affected by atherosclerosis. This is a very important to be classified as extreme high risk inside the population with secondary prevention. And finally, multivessel coronary artery disease. So they are not in the same basket. We have an extreme or augmentation of the risk in the first year post-acute acute coronary syndrome. And we have subgroups that more than one territory, more than one event, multivessel coronary artery disease, all of this population representing an extreme high risk inside the population with secondary prevention. Let us go for real life. This is the second bad news. The first bad news I told you in primary prevention, not all myocardial infarction patients for the first time in their life are, if we classified them, may not find them, all of them at high risk, and there is a good percentage of them that if we stratified them, we may find them at low or intermediate risk. The second sad news in secondary prevention of this data. This is coronary heart disease patients from 14 countries, from the all 6 continents or region of WHO, recruited 4,500 participants enrolled between 20 and 23, and look for the data. This is an InterSpire data outcome that there is 67% not at a physical activity target, 67% are dysglycemic, whatever diabetic or having impaired fasting glucose, 61% blood pressure is not controlled, 91% didn't attend the cardiac rehabilitation, 83% the LDL is not at target, central obesity is a 41%, and 13% actively smoking after the event of or diagnosis of cardiovascular disease. This is a very important data. And so handling this disappointing number of figures, we have to know that we have only one way to escalate our treatment. This is for lipid, to escalate our treatment and driving our treatment for secondary prevention, whatever subclinical, first event or recurrent event. We have one way to escalate our treatment, but we have also to look after to the lipid biomarker and the other risk factors, especially for the lipid biomarkers, lipoprotein little a, CRB, and other parameters of lipids that we should revise it before, especially in those high risk population with recurrent event or multivessel disease. Going back to aspirin, aspirin is an essential part of treatment for secondary prevention, and adding very low dose aspirin to rivaroxaban for those with high risk stable secondary prevention is one of the rationale. But for the whole population with coronary artery disease after acute coronary syndrome and having DAPT therapy for the first 12 months, I'm sorry, for the first year, then default strategy is to continue with aspirin for life, indefinite, once we got out of the first year after acute coronary syndrome. This is the default. So recommendation of patients with coronary artery disease is aspirin 75 to 100 daily, is recommended with the previous myocardial infarction or previous revascularization, class 1 indication with level of evidence A. Aspirin is recommended for all patients without contraindication at initial oral loading dose 150 to 300 and maintenance of 75 to 100 for once daily for the long treatment. In acute coronary syndrome, DAPT with B2Y12 inhibition in addition to aspirin for the first 12 months, and this indefinitely or after that. And those with chronic coronary syndrome, it is recommended to add clopidogrel first, but will continue definitely on aspirin for life. And what is guideline directed for aspirin for an important version of European Society 2019 to 2024, an important issue. It is recommended, as I told you, for patients with chronic coronary syndrome to go indefinitely and have some depth, but aspirin for life. But an important issue that it changed from 2B indication to class 1, that aspirin 75 to 100 milligram daily may be considered in patients without a history of myocardial infarction, without a history of revascularization, but with the definitive evidence of coronary artery disease on imaging. This had been translated in the current version of European Society of Cardiology recommendations from being 2B to class 1 indication. Mr. Chairman, Professor Adil, I can conclude my talk about prevention and rethinking and prevention for primary and secondary. In primary prevention, risk scoring is in continuous development to bridge the gaps in appropriate prediction of our patients, involving more variables and integrating risk enhancers. So once you developed your risk scoring, you have continue to evaluate it in the practice and having your developments more and more with time. As I told you, some or a group of patients having the first myocardial infarction, if we put them in the risk score, we find them as not at high risk. Currently, my recommendation to our followers to use the risk scoring, but you should individualize the patient care, using and looking for risk enhancers, looking for other parameters of you still having risk enhancers like highly elevated CRB, like lipoprotein little a, until we got risk scoring, having this data integrated into the risk scores. In secondary prevention, although patients at very high risk, but not all of them in the same basket. Some of them are at extreme risk and should have more care, especially those in the first year post ACS, and those with multi-vessel disease, multiple events, and multiple territory that affected by atherosclerosis. Addressing the phenomena of worldwide poor control in secondary prevention should be tackled in all ways, whether this inertia, whether this adherence, lack of adherence, lack of knowledge. And I think our targets today to spread the knowledge will help a lot in tackling, especially those in secondary prevention, as they will subjected to an early second event if they get into targets for all risk factors before having a second event. Thank you so much for your attention.
Thank you very much, Dr. Basim, for that excellent and elegant talk where you took us through primary and secondary prevention. You gave us a full roadmap on how to manage primary and secondary prevention. I again welcome. We have more than 300 participants in this session, which is a very impressive number. And this, if it indicates the need for such webinars and the thirst of our healthcare colleagues in the healthcare space in cardiology, primary care, internal medicine on this subject. And just going to the questions, we got a question from Mamdouh Al-Hosawi, who is a Saudi, and he's a graduate of the USA in cardiac rehabilitation, who wants to reconnect and participate in more and more of these collaborations, and we're happy to do that. Uh, Dr. Mustafa Najjar has a question for you, Dr. Bassem. Um, my question, what's the future plan of preventive cardiology in both KSA and Egypt once we put our hand on moderate and high risk cardiovascular disease risk? In other words, when can we see proper management of those clients like we know from updated guidelines from ESC or AHA ACC? So maybe Dr. Basim, you can tackle this question. You are on mute, Dr. Basim.
Okay, thanks for the question. And I think this is an important question for two reasons. We have two problems to adopt the guidelines in our current practice, and we have to know that we have to have our local risk scoring because our patients are completely different than the other. And as I showed you on my slides, the forecasting of traditional risk factors from 2025 up to 2050. So in the next 25, the map of the traditional risk factor will be changed according to different factors globally. So we have to adopt our local guidelines, have to have data from our patients. I think so. King Saudi Arabia had been advanced this and have their own local database to be translated into risk scoring and improving the risk score over time. This is not one step process that you create the score and stop at that. You have to, in a continuous feeding with the data and the new data and validation over time to reclarify and reinstallate. And I think that the European risk scores an important example for that. They are improving the risk scores with time. We have score two. There is a previous versions of the scoring. So collecting the data and the continuous process of collecting data and updating the data will find our way to create our local risk scoring. And at that time will be a second problem, how to implement. So this is an important to rising the knowledge, spreading the knowledge through such great meeting that I honored to have it with Dr. Adil. Once we spread the knowledge, they will help to implement our redefined, locally elaborated risk score from our region.
That is an excellent comment, and I just want to add to that. Data is the most important, and then analysis, the proper structured data, and the analysis of this properly uh, gathered structured data, both on the preventive side. So we do need risk calculators and risk calculators with a memory that will always keep us on track, and training the primary healthcare physicians who are the gateway of the healthcare system in most of the countries on the proper use of such risk scores and the proper identification of risk factors. This is of extreme importance. And of course, adding extra elements like chronic kidney disease, chronic metabolic syndrome, kidney metabolic syndrome, and of course, having that data longitudinally. So if the patient does have a risk score, then this patient is followed also with an acute coronary syndrome risks data collection if the patient presents with an ACS. In Saudi Arabia, we have both. We have the cardiovascular risk calculator, and in fact, from the beginning of 2025, we started a new project with the American College of Cardiology where we are rolling out the NCDR registry in two pillars, which is chest pain MI and cath lab PCI, where we are linking both the preventive data and or the risk scoring with the event data, which is which are the patients who are presenting with non-ST segment elevation MIs and ST segment elevation MIs. And then from this exercise, we will be able to make the risk score more and more accurate. And as you mentioned previously, we do have an underestimation in our Arab world using the risk scoring systems which are based on the Western population, either the PCE, AHA, ACC, or the score to European scores. And I think having that in hand and understanding more and more about our population will give us the winning streak. There is another question, and this is for you, Dr. Basim. Since not
Yes.
all secondary prevention patients are at the same level of risk, what are the most reliable criteria in secondary prevention to identify those at extreme risk and who need more intensive care?
Yes, of course, I asked this question for the first time in starting to discuss the secondary prevention. All secondary prevention patients are at very high risk. So risk stratifying inside those patients, this group of patients, we have to select patients with the first year post ACS. They are considered, and you should have strict target to be achieved as early as possible, reducing the blood pressure, reducing blood sugar, controlling LDL. This is an important to reach it as early as, because they are extreme of risk and they are having a peaking of risk for the first year post ACS. This is an important subgroup. Another important subgroup that they have patients who have repeated events in a very short time, 1 or 2 years, have two events. This is an important subgroup that you have to focus to reach your targets as early as possible. An important population that may have the data of using aspirin and low dose rivaroxaban, the patients that have atherosclerosis in more than one territory should be considered as extreme high risk population in the population of secondary prevention. And finally, the patient that have a multi-vessel disease, coronary multi-vessel disease, or especially those we couldn't revascularize them, whatever, as Professor Adel job by coronary artery bypass grafting, or by from my side as PCI cardiologist. So whatever incomplete revascularization in a multi-vessel disease population, this considered patients that already should have more care, as they are having an extreme risk inside the whole population of secondary prevention.
Thank you very much, Dr. Basim. Our last question for tonight, how can we guarantee the smooth transition of care of patients with multiple chronic diseases such as diabetes, hypertension, specifically between tertiary care centers to primary health care to control risk factors? Are these going to be future programs? Are there going to be future programs that can help healthcare professionals to ensure this for all patients? And I think this depends on two things. First of all, organization structure of the healthcare delivery. And we do have in Saudi Arabia a new Saudi model of care, and it's quite unique, where preventive population health, preventive, primary, secondary, and tertiary care are quite well knitted and talk to each other. And the one of the major advances in Saudi Arabia now is trying to connect them technologically through a streamlined or and health information exchange, we developed a program which is called Nafis, which is the like a unified medical record for the population. And in that way, when you have that technological enablement, you can follow patients from primary all the way to tertiary care, and then back to primary care. Because the one of our problems is the patients, after they get an event or they are labeled as high risk, they are stagnating in the tertiary care. And we all know that when you need to do prevention, either primary or secondary, uh, the tertiary care hospitals are probably the worst places to do that. But when you have a primary care setting connected to tertiary care and streamlined in a seamless fashion, then you could do both primary and secondary prevention at the primary care setting, and with better access for the patients and better control of their chronic diseases. If you have any final words.
Uh, I think regarding the integrated care, we can call it an integrated care. We have uh, uh, some milestones in Egypt, making the educations, meetings, conferences. It's in a multidisciplinary team approach. So this is an important step. And for on the service level, we have a little bit starting an important issue of networking. I'm working at the National Heart Institute and Specialized Center for Cardiac, but we have a network of uh, 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 other services like nephrology, diabetology, and so on. So to avoid missing something and have a decision making that already fitting for our patients, having a multidisciplinary team, so the decision will be revised by the other aspects that already, and I think we are so much integrated in that way because science is moving in the same way. The drugs of yesterday that were prescribed for diabetes nowadays prescribed for heart failure patients, prescribed for decreasing cardiovascular mortality and morbidity. So the science, the attitude, the policy, and even the service are moving to have an integrated care to help our patient and not to prevent them having the best care.
Thank you very much, Dr. Basim. The last word is integrated care. That is the secret recipe. I would like to thank you, Dr. Basim, for this elegant talk. I had the privilege of being a co-host with you for this session. I would like to thank Bayer for sponsoring this event. I would like to thank special thanks for the Saudi Heart Association and the great team behind putting this event together. And I would like to extend special thanks for the 300 plus participants who listened to us today. I hope that the messages we wanted to reach out with are clear, and looking forward to meeting you all in both virtual and physical events very soon. Thank you very much.
Thank you. Thank you so much, and I want to like to thank the audience because the attendance is phenomenal, actually, and it's a pleasure and honor having these meetings, and I hope to have an opportunity to repeat it in the near future, inshallah.
Thank you very much. Thank you. مع السلامة.
Bye bye.
مع السلامة.